The stellate ganglion block, which is a little different, can be done also. I've seen it done at bedside. Okay? It's, the most irritating is really you're all over the face, you're all over the area of where the patient is the anxiety of the patient itself. Okay? The stellate ganglion block is mainly addresses the upper extremities. If they have RSD, CRIPS, complex regional pain syndrome of the upper extremity, whether it's the right or the left. So if it's the right, you do it the right stellate ganglion block. If it's the left, you do the left side. You don't really do bilateral. So basically, you feel the notch around. It's the 6th cervical. That's when you feel it there. You take the needle, you hit the os, and then you aspirate, give the medication. We normally do this on the fluoroscopy, where we'll give a dye to make sure we're within the range. Because, one, if you get into vascular, the cervical region is very vascular, highly vascular. Vascularities are pretty close by. Should your local go into the vessels, uptake, you can have a lot of side effects from it, bleeding, you can develop hematomas, so you have to be careful on a lot of things. What do you expect to see from a sympathetic block at the stellate block? Is like you need to see a Horner syndrome. So some degree of Horner's will develop. What is that? It's pinpoint pupils. You have the droop of the eyelid. You need to see a little bit of that. You also need to see increased flushing in the arms. You need to see redness. So that tells you that you've gotten the appropriate area, you've blocked it. The block, because we're giving ropivacaine, which is a 12-hour acting, those symptoms will last for roughly around 12 to 18 hours. So the patient sometimes will panic, but this is what you have to tell them. This is what we need to expect to see. And if we do not see, then we didn't do our job right. And the effects are temporary and will resolve. Some of these complications, okay, you can develop pneumothorax. It's easily, you can get it, you misplace, you're not paying attention, it can be done. You can get development of hypotension, so you need to be careful with this because it's a sympathetic block. You can have all of these can occur, seizures, if it gets into the bloodstream. Most of these complications can be avoided under fluoroscopic because we do give contrast. We make sure that it's staying there. We see that it's not an uptake into the vessels. And the other way to avoid hypotension issues, you set up an IV access, and should they develop some hypotension, you just give them a lot of fluids, and you give them a little bit of Ativan prior to, so they're not so anxious, so they're not getting vasovagal on you. So all of these can be prevented most of the time. Another one that is also very beneficial, can also be done at bedside, but we do also under fluoro, is an intercostal nerve block. When is it really indicated? Like rib fractures, chest wall, contusion pains. After thoracotomy tubes, they can develop severe pain in the areas. Sometimes even liver biopsies can cause severe amount of pain in that region. So it's basically in the area especially if it's a thin person, you can palpate the ribs itself. You can palpate them. You put your finger and you're entering slightly inferior to that rib and staying right under it. It's very simple. But if it's a big person, it will be harder to palpate the ribs. It'll be harder to get the landmarks in there. Because if you don't follow and stay close to the os, you have the lungs. And you can end up with spontaneous pneumothorax. But as I said, in a small, thin person, using a very small 1.5-inch needle, palpating, going under the ribs, you can get a nice block. We do this as well under fluoroscopy with contrast, so that kind of takes a lot of the risks to minimum. But if a patient is not able to do that, they're having a lot of pain, you're at home, bedside, this can be done pretty easily. The other types of blocks for abdominal pains that are available, it's called the ilioinguinal, iliohypogastric, genitofemoral neuralgia blocks. Genitofemoral I've used for chronic pelvic pain. I've used pain in the area of the scrotal, penile regions, pain associated with sexual intercourse, because some of the areas in the skin areas are very irritant in a male or a female, and they need the block. I don't know if I have a picture of where it is, but it's basically in the pelvic rami. It's done on fluoro, and it's pretty easy and can give you immediate relief. Let me see if I have a picture. No, I don't. How do I go back? Okay. All right. Yeah. If we think of the abdomen, right? You have the abdomen, and you have the umbilical cord. Can we put this up? Okay. So let's go to the, all right. And then for the, this is the pelvic. For the genitofemoral, you have the pelvic area, the pelvic rami. Basically, under fluoro, you see the pelvis, the pelvic rami, and it's basically right at the 1/3 from the tip, beginning of the rami, and you hit os, and you basically get a genitofemoral nerve. The ilioinguinal nerve, or the iliohypogastric nerve, is from the ASIS point, and you're making a sort of line to the umbilical, the belly button, and then you go about approximately 3 centimeters and about approximately 2 centimeters inferior to that point, and that's the ilioinguinal nerve. You go higher to that point, about roughly 2 to 3, then that would be the iliohypogastric. Ilioinguinal, iliohypogastric is pretty much a sensory nerve, okay? So these are pains in the ilioinguinal, could be pains all in this area. Iliohypogastric could be pains coming in this way. One of the major reasons is after surgery, the ilioinguinal compressions occurred by adhesions, mainly from hernia repairs and meshes and stuff, and they tend to have a lot of pain going down into the lower part of the abdominal, sometimes into the groin, sometimes even into the genital region areas. It's so diffuse, they don't know where it's coming from anymore. So that can be blocked very easily. You can do it under fluoro. You can do it under it's like a portable EMG machine if you're going to do it at bedside, so you can get it easily. You don't need to have it. This also can be done something at bedside. More of the rehab-trained fellows tend to know what that is exactly and how to do it, because it wraps around from the back, from the lumbar plexus, and intersects in between the externus obliquus and the internal obliquus. So it's in between 2 muscle layers. So when it comes through, it's through 2 muscle layers. So when you're going through it blindly, and you basically marked your landmarks, you feel the needle going through 1 layer of muscle, and then you'll hit a layer where you know you're still on top of another muscle. It's just a sense of feeling when the needle's going through. And then if you do it with a needle, EMG needle, with a little bit of an EMG portable machine that's guided, you turn on the EMG, and the electrical stimulus goes through that needle, and then you ask the patient, because this is totally sensory. If you push the needle too far down, get the femoral nerve. then they'll say, oh, I'm feeling it all the way down into my thigh. I feel twitching. That's not what you need to hear. Then that means that needle is not in the right position. So you have to pull back and then reposition the needle. What you need to see is that I'm feeling a burning, tingling, numbing sensation going down into the groin, into the lower abdominal, maybe into the genital region. But not into the thigh, not going all the way into the legs, not in that region. Then you give your little local, you get an immediate relief. Iliohypogastric is pretty simple. It's the same kind of a block compared to the ilioinguinal, but you're doing it a little more superior. They have immediate relief, and if the relief you want them to continue, then you can do radio frequency on these nerves. Then that will give them relief for a longer period of time, for at least 6 months to a year. They can do cryosurgery. They can freeze them. So these are basically all sensory nerves that can be addressed very easily.